welcome Dr. Kristen Cook.
Well, thank you, everyone. I am new to this position for 5 months. My official title for that is Director of Equity and Inclusion. I've worked as a pharmacist for 17 years, and I've primarily worked in the clinic setting. So I've worked at the VA, I've worked at federally qualified community health centers. I now work here at Nebraska Medicine in an outpatient clinic, and so we actually just hired our first technician in our primary care clinics. Is it you? Are you Rebecca? Oh, okay, awesome. Well, there we go. Nice to finally meet you. I've gotten lots of messages from you, but so yeah, it's great to have technicians working alongside us in the primary care setting as well. So I'm happy to talk to you guys today. Talk a little bit about cultural humility and social determinants of health. I didn't know that there were requirements in some states for CE in this area, so that's great. Nebraska is not one of them, and this is a huge topic. So obviously can only really kind of scratch the surface at best. So I guess my approach to this is kind of to talk a little bit about some different terms, some different things to think about, and then I do have some individual case vignettes for you guys to kind of interact with each other and talk to each other. So I'm going to make you actually participate. And for those of you on Zoom, hopefully we can do that via the chat as well. And so then we'll kind of wrap up. Hopefully we'll have time to talk a little bit about health literacy and some issues related to that. And also working with patients where English is not their primary language. So whenever I think about talking about this issue, it can be an issue obviously where there's a lot of feelings surrounding it, but whenever we talk about it in the classroom setting, which is where my primary experience is, thinking about psychological safety. Are you guys familiar with that term? Hopefully this is something, I'm talking about this from the perspective of taking care of patients, but I also obviously think this is a huge issue in our own workplaces as well, with our colleagues, our bosses, our teams, things like that. So hopefully this kind of spans everything. But we always try to kind of think about psychological safety, which is obviously a place where people feel comfortable speaking up. They feel kind of related to maybe what Dr. Cochran just talked about, bringing up mistakes, talking about ways that we can improve, in all kinds of different ways. And so whatever your workplace environment is, I think this is an important concept for you to think about. Do you feel like you have a psychologically safe workplace? And if you don't, what are the barriers to that? Thinking about intention too when you're thinking about this. And so kind of we all have things to learn in this space all the time. It's ever changing so thinking about how can we learn from each other and being open to talking about those issues and admitting when we don't know what the right term is or admitting when we don't know what the right path is and figuring those out. And so making sure we're thinking that being intentional about it and not always thinking that someone is coming from a punitive place on this. So. I have this up here just as an example, and you can think about it in your own workplaces. Whenever we talk about these issues in the classroom, or we're going to have a discussion, we usually try to set ground rules for the group, and everyone participates in this, and everyone kind of says like what they think their ground rules should be when they're discussing issues. People can share if they want to. They certainly don't have to share experiences as well. That's totally up to the person, but I think if you're thinking about this in your own teams at work, having these kind of ground rules for discussion, really of any topic, I would say, is always a good thing to think about to create kind of an inclusive work environment. Okay, so this is a graphic that UNMC Nebraska Medicine uses, and kind of just touching on a few of the different terms we're sort of going to talk about today. So thinking about diversity, equity, and inclusion. I think the big thing with this is that we can have diversity across our teams, obviously across our patients, across everyone, and that's great, but we also need to take it to the next step. So are those voices being included in the decision making? Are they being included in the conversations that you're having? Does everyone from diverse backgrounds feel comfortable speaking up and sharing? So that's the inclusion part. We'll talk a little bit about equity as we think about taking care of patient populations and different patients. How can we create equity within our pharmacy spaces, within healthcare in general, and kind of the difference between equity and equality. I have a graphic here later on that I think helps kind of demonstrate that. But again, creating policies, modifications in your pharmacy, ways you approach things that really create equity. And hopefully when we put all those pieces together, which doesn't always happen perfectly, certainly all the time, that we're creating belonging in our workplaces and for our patients. This is, again, the diversity wheel that our organization has. You guys may have different things within your own organization, different committees, different approaches to this. I like this because it looks at internal, external, and then organizational. So when we're building teams to make decisions, or if you're trying to talk about things you want to change within your pharmacy, thinking about all those different factors that could impact decisions and are all the voices at the table. And so I think certain things come to mind when we think of diversity, equity, inclusion, and those things are definitely important. So we have race, gender, sex, ethnicity, age, sexual orientation. Those are all internal factors, but we have a lot of external factors that can influence our perspective as well. So things like educational background, language, all of those types of things. And then even within our organizations, so what role do we play? Do we have technician representation on a committee that's deciding about a policy, or is it just pharmacists? And so kind of thinking about those roles that we play, how long have people been within the system? Sometimes I've been within a system for 17 years. My perspective may not be as fresh as someone who is just starting within a system. And so when we're building teams and kind of thinking about inclusive workplaces, thinking about all of these different things. Okay, something to just get you kind of talking with each other. So what is culture and what are important parts of your culture? So I'm not going to require you guys to share, but if you guys want to talk with someone near you, and maybe just share, if you feel comfortable, a couple different important parts of your culture with a close seatmate, I guess, here. And then we'll come back.
I grew up basically in Dallas, literally right down the floor.
Okay, I'm going to bring it back together. You guys can share with each other. With like a buzzer. Maybe you guys can come back together. thank you for this. I don't have like a booming projecting voice, so I'm sorry. Hopefully you guys had a chance to share with each other and certainly can continue this conversation after this presentation would be great. But hopefully an opportunity to share a couple of things that are important to you in terms of culture. When we think about culture, really it's a shared system of values and beliefs. And so it can be varied definitely from person to person. And it encompasses all these things I won't go directly into, but expressed in views, attitudes, and behaviors. So understanding culture of your patients, culture of your colleagues can be important to understanding why they might react to a situation the way they do, or maybe different ways that your patients might need you to approach them or to help them. It's often individually defined. This is from the Boston University School of Social Work and kind of a well-known presenter on cultural humility. And sometimes we hear the terms cultural humility and cultural competence, which I have another slide here that kind of talks about the differences, but really realizing us learning about other people's cultures involves a lot of self-reflection. What are some of our biases? What do we know about other cultures? Where are we coming from our own culture? Talking about power imbalances, this talks about the patient-provider relationship. And so with the patient-provider, the patient-technician, patient-pharmacist, whatever that relationship is, understanding that that person is the expert on their culture. And so allowing them to share that with you, decisions they might make, perspectives they might have about medications, or different healthcare decisions, that they're the expert on that culture, and making sure that that is recognized to help with that power balance. Developing mutually beneficial partnerships with communities on behalf of individuals and defined populations. So some of you may work in pharmacies that serve particular groups of patients, and so really making the effort to understand what's going on in that community that you serve, and how you can actively participate, in this case as technicians helping for the health of that community and with their medications. We used to use this term cultural competence, and I come from the pharmacy education world, and so we have these educational standards that we have similar to probably other organizations that have certain standards. And so we always had cultural competence as an item we were supposed to be teaching our students. And that's great. I think the intention is good. The shift in our standards now has been more to cultural humility. So competence kind of gives the idea like you're going to be the master of all cultures, and you're going to master this area, when in fact that's just not really feasible to master all cultures. And so we're always, all of us, learning about different cultures from our patients and our colleagues. It's dynamic. It can change. People's culture certainly can change over time, and that it's personal and authentic to that person. I'm thinking of it more as a partnership versus like, I'm competent in your culture, let me tell you how to manage your medications within your family, or manage your medications within whatever system you're using. And hopefully it's more of a path to equity versus that competence term. So why do we care about this, or why can it be important for us as people? So we all likely serve diverse communities in some way, shape, or form. And so I worked in geriatrics for a long time. I work in primary care now, but when I was serving more of a geriatric population, understanding some of the things that impact that community. And so whatever community you serve, we're going to be serving diverse communities across the board. When we think about healthcare disparities, I'll show you guys a couple graphics here in a second that really just kind of demonstrate some of the disparities that we have here in the United States. But as we try to start to address these disparities, maybe in access to medications, for example, having cultural humility and being able to learn about culture is important in that piece. Patient safety. Why might it be important to patient safety? Anyone want to tell you what you said? Yeah, communication, right? So some of you are likely communicating with patients. And so when we're working, for example, with interpreters, or if we're working with someone who doesn't speak our language, our ability to talk with that patient, at the counter, or talk with that patient at the bedside, or wherever we're doing that, really can impact patient safety. If they don't understand what you're saying, if you can't communicate appropriately, that's super important. And then our healthcare workforce, yeah.
Also, probably the adherence,
Yes.
make sure they're taking it correctly.
Yeah, absolutely. Yeah. And as we talk, even hopefully we get to at the end about health literacy and things like that, but if we don't communicate how a patient's supposed to take a medication correctly, or we don't help with that, then adherence is going to be a huge issue for sure. And then our healthcare workforce. So trying to recruit a diverse healthcare workforce, that our healthcare workforce represents communities that we serve, that it is more diverse. And so all of these things are just some of the reasons we might really want to start thinking about cultural humility in our own workplaces. Thinking about cross-cultural communication, so we can't understand every culture, right? And every individual's culture, even with what we might assume are people that have similar cultures, can be different. So my daughters are a different race than I am, and so they're Chinese, and so people might look at them and make some assumptions about their culture, things like that, but in fact it is different than other people that are Chinese. And so kind of thinking about that, and that we can't understand it completely unless we talk with the patient. And that gets to roles that I think technicians can play great. So you guys likely might be ones that know your patients pretty well that are coming into the pharmacy. You're talking with the patients when they come in. You're talking with them when you bring medications to them at the bedside in lots of different forms. And so you may know some of these things about patients. So do they have different beliefs in medications? Do they have alternative medicine that they prefer? Do they not trust the medications that they're picking up? And why might that be? Are there family dynamics at play that we need to really think about? And so I think sometimes I've seen this happen. I've worked in the clinic setting where providers or people that are talking with patients are making decisions about their healthcare or medications that to us don't seem like the right decision or the most appropriate decision, not following our recommendations, things like that. And sometimes this piece of actually talking with patients and really digging in, why are you making that decision? What's influencing that? And it might not be a decision that we agree with necessarily, but sometimes we have to actually work with that then. I have implicit bias. We could, again, do a whole, we could do a whole session on this. But kind of just as you're thinking about cultural humility and interacting with patients, acknowledging that this really exists for all of us. And so this is maybe stereotypes or attitudes that we might bring to a patient situation or an interaction with a colleague that we're not really aware of, that we have, that bias. Ultimately, in the healthcare system, these implicit biases can occur that can sometimes lead to explicit bias of certain populations, and then we have our inequities and disparities. And so I think I have this later on, but there are implicit association tests you can do online. Harvard has a whole set of them out there. I think there's a lot of debate about their utility, but those are out there as well as a tool. And then I think this is another important point to think about when we're talking about cultural humility, so equality versus equity. And I like this graphic. I think it does a good job demonstrating a little bit the difference between the two. And so equality in this graphic is where each person has a bike. So everybody has access to a bike. So that would be giving them, equal access to the bike. But if we look a little bit closer, this patient has access to the bike, they can't really use it. This bike doesn't necessarily fit this person, but everybody has access to that bike. The equity piece is actually creating systems, policies, interventions that are tailored to the individual patient groups that we're serving to help with those inequities. And so we see modifications of that bike to actually fit those people to help them. And so a lot of times within our healthcare system, we may say, well, everyone has access to healthcare. Everyone does not have access to healthcare in the US. But if we say, okay, this group of patients, they all have access to this insurance at this workplace, great, they may have access to that, but their ability to go to a clinic, their ability to implement lifestyle modifications can be impacted by so many different things that thinking about that piece, that not, we hand someone insurance, that doesn't mean that they're going to have great health care. And that can be, again, the case for our patients that we're serving or our colleagues. If you're interested in healthcare inequities and disparities, there's tons of data out there that you can certainly look at. And if you serve a certain population, so if you work in a pharmacy that serves LGBTQ plus patients, then you can certainly find a lot of data on inequities and educate yourself about those inequities that are occurring in your patient population, which I think is a good thing to do if you're serving a particular area. The Kaiser Foundation is a group that puts out a lot of data on healthcare inequities. And again, these are just up here to kind of demonstrate, yes, that these inequities exist. And these are challenges that as technicians, healthcare providers, that we really need to be actively participating in and engaging with how we can help with these. So for example, this is the maternal mortality by race and ethnicity from 2018 to 2021. And you can see that there's a significant difference between white patients versus Black patients versus Hispanic patients. And so starting to dig into why is this occurring and what can we do within our own systems and policies to help with that. This looks at diabetes. So diabetes is kind of, I would say, my area of expertise in primary care. But if we look at age-adjusted death rates for different race and ethnicities, for diabetes, we again see some pretty significant differences between white patients, Black patients, Asian patients. This is American Indian, Alaska Native, and this is Native Hawaiian, other Pacific Islander. So we definitely see differences in those. So if you work in Indian Health Services and your pharmacy is there, knowing about some of these inequities and starting to think about why they're happening and what can we do to help with that. This is my last slide I'll give you guys before we put some cases up. I think whenever we're talking about cultural humility or we're talking about trying to take care of patients, it's always important that social determinants of health, roll into this. And definitely with inclusion and equity, they're kind of intertwined. So we focus on this a lot with our pharmacy students. And when we're talking or they're learning about a particular disease state or medications, thinking about how some of these social determinants of health can impact a patient's ability to be adherent, can impact a patient's ability if we teach them how to eat healthier, what could potentially impact this. And this is again from the Kaiser Foundation, but when you guys are talking with your patients, certainly things like literacy, language, education, vocation, things like that can certainly impact those. People's ability to get to the pharmacy or to get to the hospital. So travel, do they feel like it's safe for them to get there? Do they have trust within the healthcare system? All those different things then can roll into health outcomes. How many of you guys work at a place that actually assesses social determinants of health? Or any of these? Okay, a few of you do. Okay, awesome. We just started doing this, trying to implement it at Nebraska Medicine, but our electronic health record has a system in it now that we can document different social determinants of health. So whoever pulls that chart up or looks at that patient can see those and kind of keep those in a frame of reference. Okay, so we're going to go through some cases just to kind of get you guys thinking and talking with each other. So the first one is a community pharmacy setting. So you're working in a community pharmacy that serves a large Latinx population. Your pharmacy offers vaccines to patients. You notice another pharmacy technician at your work has stopped asking most patients if they're interested in getting COVID-19 vaccines. You ask them about it and they respond, most of the Latinx patients don't want it even when I ask, so I just stopped asking. Okay. So again, you can partner up with someone beside you, but why do you think this technician is associating ethnicity with lack of vaccine uptake? And what could you do as the technician in this situation to help or handle this? So I'll let you guys discuss. I think we'll come back together. Does anyone want to share anything that they talked about?
We had a lot of mistrust from the government.
Yeah.
Okay.
Lack of understanding of what the vaccine is and
Okay.
the language barrier.
Because the
Okay.
CDC did not put out a very good, consistent
It changed
information.
Yes.
so much. So at that time, the information we were getting from the government and from the scientists it was always changing because it was so new
Okay.
that
Yeah.
the general population didn't understand why it was changing so rapidly.
Okay, great. So maybe some communication breakdown. Somewhere could be language, could be other things, and then possibly mistrust. Okay. Yeah.
Perception.
What's that?
Perception came up in our discussion.
Perception.
Perception. Okay.
Perception,
Perception. So what do you mean by that?
how we saw that person.
Yes. Okay. So how that
Their skin
technician.
color, their dialect.
Okay. Yeah.
And so we quit asking them that question.
Yeah. Great point. Yes.
Just complete assumption, like just assuming that since I've asked, even if they weren't family members or the particular Latinx community as a whole, if you try and follow trends, which I think that's what we do, to meet numbers and especially in the retail setting, you just kind of see, okay, who is, instead of it across being somebody or being across the board, it's like who's most likely. So you end up assuming like, okay, we'll try a different, set of people. So I think it's just assumption.
Okay. Great. Thank you for sharing. Yeah, I think perception is a huge piece of this possibly, and unless we talk to that technician, we might not know what's going through their mind. And I think that's an interesting point. So from a retail perspective, you're right. So we have maybe systems in place that incentivize us to figure out who
Yep.
we think is going to. Yes.
It's also generational, it's not just ethnic, it's generational, your older people or your younger people are, and there's so much, we discussed, there's so much misinformation out there.
Correct.
And you're getting it from bombarded, and unfortunately, so many people believe everything they read on social media or even the news, and they don't bother to really check the facts and stuff.
Yeah, that's helpful. Yeah. In this case, it was Latinx patients, but certainly this translates to lots of different groups, right? Okay. Lots of different people. Anyone have a way they would handle it with that technician? Or what they might do?
The rule,
What's that?
and then tell them, well, you're required to ask them no matter what,
Okay.
whoever they are.
So utilizing
What happens.
rules or policies that are in place. Okay.
I would probably have a crucial conversation with that technician, gain their perspective and maybe see from their point of view, their lens, and try to eliminate those assumptions on my end as a leader or an informal leader.
Okay.
And then that will, I believe, would open up, like that open door policy, and create, give them more like encouragement to kind of speak up as to like why they may not feel comfortable doing or giving that recommendation.
Great. Do you have training in crucial conversations? Okay. I was like, that's a buzzword to me. But yes, I there's a lot. I know what you're talking about. Yes. Anyone else? Okay. Well, I appreciate you guys all sharing. I think those are great ideas. I think, sometimes we do use policies, like we have to ask everybody, and this is just part of our job and what we need to do. I think the crucial conversation piece, addressing some of the things you guys brought up about perceptions or assumptions we might be making about an entire group, and why that technician is perceiving that way or making those assumptions. That conversation might be really productive. It might not, but it might be productive to kind of get them to talk through why they're approaching the situation this way and maybe end up changing their behavior. I just have some tools in here. Hopefully you guys have access to the slides and can maybe look at these later on. But I think Always, if, for example, if you're a technician training a new technician or talking with someone, having that open discussion orientation to not only the pharmacy and the process, but the patients that you all serve, and who those patients are. This got brought up about language, communication, how are we communicating, the mistrust piece. We might have to tailor our education to that mistrust piece. I think we've, for people that are advocating for vaccines, we've had to do that already due to a lot of the reasons you guys brought up. But it can be particularly difficult across a language barrier. And so we have different standards. And then this Learn tool is a great tool to utilize in your pharmacy if you're interested in cultural humility and kind of implementing that more in your pharmacy. It is a great tool that you guys can look up later, certainly, but it's meant to enhance cultural awareness of personal and cultural beliefs. And it stands for listen, explain, acknowledge, recommend, and negotiate. Crucial conversations, which I missed your name. Anita brought up, is another tool with it, which there's certainly videos out there and there's specialized training in it as well to have these type of conversations too. Okay, second vignette. So we're still in a community pharmacy. You're working in the community pharmacy next to an endocrine clinic that provides care to transgender patients. Transgender female comes in to pick up a prescription for a new antibiotic. You ask another technician to greet the patient and see if they need counseling on it. The technician says, I'm scared to talk to the patient. I had a previous difficult encounter with a transgender patient where I used the wrong pronouns and they yelled at me.
I had that experience.
All right, how do you handle the situation?
I had that, which was really fun because the transgender couple that was behind her pulled me aside very nicely and said, don't take it personally.
Okay, all right.
It was very nice that they pulled me aside and said, because I was raised in a military family, everybody was ma'am and sir.
Sure, yeah.
And so you have to be more aware of the situation and try not to use the terms.
Yeah, awareness is a huge part of this, right? And something that may not come, it doesn't necessarily come naturally to everyone. I think about our students that we're educating now, and I'm a good 20, 25 years older than them, and they do a better job than I do. And so having to think about that. So I'll let you guys discuss again in your groups. So we've already got one way to handle that, which I love, but talking further about the situation, how you might handle it.
What's your name? Oh, no, and hi, Mr. And then he's like, no, call me. There we go, there's the permission.
I think for the sake of time, we'll come back together. I need a bell or something. All right. Does anyone want to share anything that they talked about?
Running.
Yeah.
What I said was pretty much, you just have to take that as, even though you were yelled at the last time, you just have to kind of walk back into that situation. And you can't be afraid. Like sadly, in this job field, you're going to be killed.
I was gonna say.
That's what it is.
Especially in retail.
Yeah. And then sometimes people, it's just a one-off instance, so even that person flipping out and yelling and screaming, they could have just been having a really bad day, and then you were just the thing that just took them over. So I've had people, and I was in the wrong, but they overreacted of my small mistake, and they came back the next time they came to feel something or do whatever they needed to do in the pharmacy and apologize to me as I'm apologizing for the mistake that I made. So kind of just taking a step back. I've learned in retail, I've worked in retail pharmacy for years now. It's just like you just have to just let it roll off your back. These people do not see you as a person. They see you as the face of this company. I need to be mad at somebody, so I'm going to be mad at you.
Yeah, I like that. Yeah, so this, talking about that dietitian, you're right, this may have just been a patient who is having a bad day. And I know all of us in pharmacy are very familiar with taking, being yelled at and kind of having that attitude, which I think is great. But letting it roll off your back. Other thoughts? Yeah.
I think too, like I would share with them, I'm in history, my background is that, so I had to learn to give myself grace.
I like that.
I had to learn how to, I'm gonna make the error because this is new. I am way older than a lot of them, so I had to learn how to, and I've been yelled at, I've had things thrown at me, I've done the things, but I've had to explain to said patient, hey, this is new for me. And so I'm gonna give you grace, can you allow me grace while we work through this thing together? And that has been helpful, especially in the ministry world, where I'm face to face with patients all the time. And it's progressed, and like you said, they come back and where's Lakeisha? I wanna talk to her at that point, because I acknowledge that it's new. I acknowledge that I'm in error, I acknowledge the things, and so just giving grace in those spaces to yourself too.
I really like that. I think that's a great approach, and you're building trust with your patient as well, which is clear as your patients come back to find you particularly. So this can be a new thing in different areas, and so I think that grace piece is key.
Now, would this be something for like as our previous in-person talked about, a systems change?
Yeah.
Basically, when we actually find out what this particular person prefers to be called, do we put it in the actual computer system where their medications are at and everything, so that if someone is scared and we can see, do they have this in the system?
Yes.
And how do we approach it?
Yes, great point. And so I think the systems is an issue, right? So this talks about further health disparities. Definitely look at this, but I had a slide about inclusive pharmacy, which gets a little bit at what you're saying from a documentation or system standpoint to help us out. And so just some things to think about from an inclusive pharmacy perspective, and this relates to more LGBTQ plus issues as well. Of course, always assessing your own level of openness, but the documentation system that you have in your pharmacy, or if you use an electronic health record, whatever your work setting is, actually asking the question, if you don't know, where do we document pronouns? Where do we document sex? Where do we document gender identity expression? How do we do that? Can we do that? And so our system, again, I work with Epic at Nebraska Medicine. We do have those capabilities now, but I'll be honest, they weren't being utilized very much up until maybe the last year, and I still think it can be hit or miss as well, depending on the intake. But that system does have that capability. Some systems might not have that capability specifically, and so even thinking, how can I work within my system, maybe to find a place to document that.
You have to be careful too, because in retail pharmacy, if you change the gender status,
Correct.
Insurance is gone.
You're correct. That's a whole separate issue.
name,
Yeah.
or to put a little comment, it also affects the insurance status.
That's
So
a good
you have
point.
to be- in the commercial side, it's much more difficult as far as documentation.
Yes, I think that's a great question and a great point too. And so are there ways to document information that's not changing the sex on it? How is that going to impact their ability to access medications and get payment for those medications? All super, super important things to ask, and complicated sometimes as well, I feel like. Yeah.
It's would be ideal if we ask direct questions, like, when you did sign up for your insurance, can you tell us
Yeah.
which gender you did choose?
Correct.
That way, that's what the notation is, and then in our personal notes, which I worked for Walgreens for 12 years, so I know you can't have a note section or somewhere you can place what the patient
Yeah.
does, identify as.
Absolutely, that's a great point. And honestly, that's a little bit what we were doing within Epic before we really actually used the functionality that it has. Yeah, you're right. And it can impact lots of things like screening that comes up, all kinds of different things. And so important to have that thought in your mind as well, because you want the patient to have access to their medications too, right? So depending on what type of social history you do, asking what preferred pronouns are, what preferred name is, I think that's an important thing to ask. And I think getting integrated into more training. We've integrated that into training our students, like when you're having an encounter with a patient, or you're talking with a patient, or you're putting a new patient in the system, what are the questions to ask? How do patients want to be addressed? Just some other things to think about. Again, reflection for your own self. What biases are you bringing? Are you comfortable asking those questions? And if you're not, is there someone there that is comfortable asking those questions to patients? And I mentioned the implicit association test. You're certainly welcome to explore those on your own if you would like. All right. I'm going to talk about this scenario, but then it's going to lead right into, I do want to get to talking about working with interpreters, because I think that's probably an issue maybe that some of you guys have run into. So this is a scenario where a technician overhears a pharmacist in taking information from a new patient. Patient does not speak English, it appears, very well, and they look confused with several of the questions. They've completed school up to 5th grade, and the pharmacist, this patient seems to speak French, has no idea how they're going to communicate or educate that patient. What do you think that technician should do? So this kind of leads into talking about working with interpreters. How many of you guys have worked with interpreters? Okay. How many of you guys have access at your work to interpreters? Okay, good. That's a fair percent, I would say. I would say if you don't know if you have access to interpreters, that's a great question to ask. And I do know that there can be variability in different systems as to what languages are available for some workspaces, but certainly a good question to ask. The term limited English proficiency, This is, I will say, kind of an older term. I think English is not their primary language is probably a better term. But again, someone who is not, which again, here in the United States, where English is supposedly our primary language, but I know we speak a lot of other languages. If you or your staff, that's the language that you're used to speaking in, how are you going to communicate with that patient and educate that patient? Anyone know the difference interpretation versus translation? So interpreting is talking. If I'm going to educate a patient, I need an interpreter. Translation is typically patient education material or written material, and both are important. Do you know at your workplaces who can interpret for a patient? So can a family member, can a child?
A nurse can interpret
Okay,
for us. A patient care technician cannot.
okay, so you have rules.
We have rules. A family member cannot.
Okay.
Because there may be a cultural problem with an adult to a child, or, so we have definite rules of who and who cannot.
Okay, great.
A lot of it, I think, is to protect HIPAA and,
For sure.
you know, and definitely not friends. And we have to ask, because we deliver to the patient's rooms before they go home.
Yeah.
We ask the patient, do you want this person here while we talk to you about your medication? Because
Great.
you may have a friend there, but you may not necessarily want them to know about what medicine you're going home with.
Yeah, that privacy piece, right? Yeah, absolutely. Yeah, I think this is another important, we certainly where I work have policies and rules as to who can interpret, who can't, but we also have pretty good access to interpreters as well. And so kind of thinking about that in your own workplace, if someone came in speaking a different language that you didn't know, how would you handle that? And how would you address it? I think that's just important to think about. Yeah.
So in the past, before I started working for Nebraska Medicine, for the company that I used to work for, they didn't really have anything in place. So like, my phone was my best friend. I would talk to this thing and it would translate to them, or most people would come in with their phones already ready. Like, hey, I already have what I need pulled up here, let me give you my phone. Like, that's typically how it works. So coming here and being able to just bolt somebody or just call someone up and say, hey, I need you to translate for me was like one of the coolest things coming over here. Yeah.
So my question would be, so if your organization does not have anything in place,
Yeah.
how do you go about it? Because I have a personal experience from, I think it was like 6-7 years ago, where a friend of mine who was a PA in a small rural town in Ohio gets a patient, can communicate with the patient, finally figured out that that patient spoke French. Well, the hospital, small community hospital, didn't have access to anyone. So that friend personally called me here in Omaha, knowing that I spoke French, and put me through.
Okay.
So again, what do you do when there isn't any structure in place?
I think that's a really important question to ask, and I don't know that I have an absolute answer to that. This comes, we teach this to our students too, our pharmacy students, and this question comes up, or there's experiences that people share where they're in a situation where there was no one that can interpret. And so, at my workplace, using like Google Translate and things like that, we're not supposed to use. And so I think advocating for interpreter services is important. And there are some standards in place for JCO, for example, about having access to interpreters. And so you can approach it from an advocacy standpoint within the organization, but honestly, I don't have a great answer for that other than to use whatever tools that you have. Unless anyone else does, I'm happy. Yeah.
In our hospital, they had a system where you could specifically call a company that handled that, and the company would have people from all different languages.
For sure. Yeah, that's great. I think some systems probably don't have the money always for that, because I think that those can be they're pretty expensive. I don't know how much they are, but I'm guessing that they're pretty expensive.
Don't hospitals, like, isn't it federally mandated? They
Yes.
have to have it?
So that's what I'm talking about with J-code, that they have to have some sort of a system in place. And I'm, again, not a J-code expert by any means. Usually when J-code shows up, people are like scattering. But there are certainly federal standards, but your question, like, how much are they followed, how much are they implemented, and things like that. And so, again, I know the advocacy piece is not an answer to that. It's AAPT.
And I think, this was years ago.
Yeah.
I'm sure things have changed.
Hopefully. Yeah.
There still is a system in place at the Med Center where family can, the person can
Yes.
sign a waiver to have their family interpret for them. And in cases where, like, I work in the cath lab and I do med histories and they're coming through very fast. For instance, family members spoke Quran or Karen, and we couldn't get an interpreter on the line. So the family members signed the waiver for the family member to interpret for them. And that worked in that case, and I'm sure they probably have that
Yeah, that's a great point.
policy somewhere for everyone.
Yes.
That would make me think though, if they can't speak English, can they read English to sign anything? That would kind of make me a little nervous also, just, I understand the need for it
Yeah.
though, but would that come up with something later?
I mean, it could, hopefully, like, your legal systems within Nebraska are within your organization are looking at that. I'm getting close on time, so I will wrap up. But I think these are some tips on working with interpreters. They're great videos. If you are someone who's going to work with an in-person interpreter or phone or video interpreter online, I think it's just important to figure out before it happens, what are your resources, what are your policies before that situation comes up, so that then you can actually implement them and hopefully communicate with the patient a little bit better. All right. Didn't get to health literacy, but you guys are welcome to look at those items and feel free to reach out to me. So, thank you.
Thank you.